Now I invite Dr. Jayaprasad sir. He will be talking about Phaco in crowded anterior chamber and post-angle closure glaucoma eyes. He is the consultant cataract surgeon at Amardeep Eye Hospital.
Good morning. Sure. Good morning, all of you. Thank you for being here. And I am talking to you about a topic which is dear to me, working in a crowded anterior chamber. We look into operating on a cataract in nanophthalmos, in a primary angle closure glaucoma post-congestive attack, and in phacomorphic glaucoma. We have 7 minutes. So, nanophthalmos, basically, we have to look at the fact that the eye is smaller, definitely less than around 20 millimeters. The sclera is thicker, 1.7 millimeters, and hence there is a higher chance for uveal effusion to happen. And the lens volume is the volume that is there in a normal eye. So, lens is big, the eye is small. Uveal effusion problems and anterior chamber is shallow. That is the situation in nanophthalmos. And the IOL formulas we use for short eyes are Hoffer Q and Holiday 2 earlier. Now we use Barrett Universal 2 for all ranges of axial length. And we can do both optical as well as immersion scan by an experienced biometrist. Before surgery in a nanophthalmic eye, always get the patient and the relatives and tell them that the potential, the chance of amblyopia being there, the need for multiple surgeries subsequently, the chance of leaving behind a high residual refractive error, the fact that you are working in a closed eye and that endothelium may get damaged and the patient may need a future endothelial keratoplasty. And mind you, nanophthalmos is also associated with Fuchs. And the potential the risk of uveal effusion spontaneously or after surgery is very high. And these small eyes are the high risk of ciliary block glaucoma, the malignant glaucoma. So preoperatively, what you should do is give IV mannitol, 1 gram per kilogram body weight of a 20% mannitol, about 1 hour before surgery or 45 minutes before surgery. I usually do under topical, but if it looks slightly difficult, a small pupil stuck, then I give a peribulbar minimal amount of lignocaine and bupivacaine and give a massage. What you see here is a Osher sweeper, that is something like a spin hook, which Dr. Osher has designed to press on the eyeball from the inferior fornix against the roof of the orbit so that a repeated maneuver will get the pressures down. The idea is, by doing all this, is to increase the anterior chamber depth and decrease the pre-op IOP so that there is a lesser chance for uveal perfusion. And prophylactic sclerotomy with the surgery, with cataract surgery, previously every other case we used to do, but nowadays with Phaco, it is advised, it's not essential because today's Phaco surgery is done in a very close, tight compartment with the intraocular pressure being retained throughout the surgery. However, when you are doing SICS where you are opening up the eye and the eye goes into hypertonia for some time, it is always better to combine with sclerotomy. There is a study from Arvind. But if you put in a sclerotomy in Phaco, please remember, don't keep the bottle high because you can get, it has been reported to have vitreous coming out or the uveal tissue coming out through the sclerostomy. Keep your flow parameters low. So here we have nanophthalmos, a small eye, this is around 19 millimeters length. Always decompress slowly, long incisions, but very optimally sized incisions. Always maintain AC throughout by injecting OVD whenever you introduce or take out a flowing instrument like Phaco or the bimanual IA. Go to step down Phaco means as you come towards progresses in your cataract surgery, you bring down the vacuum from 400 to 300, 200, 100. And even I go to 75 for the last piece so that you don't catch the PC and taste the vitreous. And Helon 5 is the ideal one, though I use just regular Oracot. Oracot is dispersive OVD. Underneath that, I use the regular hyaluronate. And for phacoemulsification, I use a combination of chondroitin sulfate above and HPMC below. And in these eyes where the lens power is very high. This was, if I remember right, 40 diopters, and I always slit the tip of the cartridge so that the lens goes out smoothly without the surface of the optic getting damaged. So once you have that slit made, then the lens can be loaded. Usually injecting through this cartridge, a higher power lens is slightly more pressure. Please remember not to overshoot and go and hit the ankle, hit the bag and create issues. So very gently, very soft pushes so that it goes into the eye nicely. And always remember, hypotony in the postoperative period is a complication which you want to avoid. Always suture the wound before you leave the table. If you have an unexplained shallowing of the anterior chamber on the table, please consider that you are getting a suprachoroidal hemorrhage unless proved otherwise. You can also get, if there is a posterior misdirection, you have put the bottle on, very high at the ceiling, then the fluid can go behind, push up, and that situation you can give mannitol, 2 pints of mannitol, pat the eye, put a cycloplegic, and keep it for the end of the day. Most probably, if it is a posterior misdirection, the vitreous gets dehydrated, AC will get formed, so you can do the surgery again on the same day or wait for a day and do it on the next day. This is another patient, very interesting patient, 40-year-old male patient, had an AC iris glow phakic IOL, a nanophthalmic eye that was done 12 years back. After 1 year, severe inflammation, so explanted. And now for cataract surgery, IOL power is 36 diopters because the cornea was steep, so power came down, and axial length is 17.5. Always do the capsulotomy through the side port. Most important thing, don't lose your chamber, then you will have radial extension. And please remember, in all these eyes, always never direct the fluid under the iris, then you will have repeated iris prolapse and you will mess up. Use a Kellman's bent tip if you have, so that you will not distort the cornea while reaching the nucleus, so that your visibility is good during surgery, and always close the wound. So once again here the pupil has been, the Seneca release, pupil has been dilated with iris hooks, and then injecting the lens with the tip opened up like a crocodile's mouth or a beak, and the beak open so that the surface doesn't get damaged. This is of course under OVD. The IOL related issues include inaccuracy of IOL, available IOL formulas, the spherical aberration involved in a large, very thick lens, the unavailability of high powered IOLs. Of course, now IOCare has started making customized IOLs for you, and the need for a piggyback or a bioptic or using contact lens or glasses for residual power. Next, let us look at post-angle closure glaucoma. This is one eye, AC is 1.3 millimeters. Post-acute angle closure glaucoma. Not able to reach the anterior chamber and do it without hurting the endothelium. So, trocar 25 gauge vitrectomy. Under irrigation from the anterior chamber, minimum vitreous is removed till the AC is deep under the fluid. And then you do it, then it becomes like a regular cataract surgery. And please don't forget to put one more peripheral iodectomy. Induced cataract in a hypermetropic eye, almost touching. So here, what I do is I put multiple punctures, a can opener in the center, so that you have multiple radial extensions, so that your intralendicular pressure is distributed along all these lines, so none of them will reach the periphery. And then you go in and massage, aspirate out all the anterior cortex, and then you go with your, now you can, once the bag is decompressed, you can go with your Uttradhas forceps through the main wound also, and there is no issue, and do your axis, and that is it. So in a crowded eyes, beware of potential complications. Phaco is far safer than SICS in a nanophthalmic eye. Always get an informed consent, and always stick to basic scientific principles. And with that, I think I'll stop. Thank you so much.
Thank you, JP sir, for that excellent and detailed video presentation.